So payers historically have defaulted coverage policy to FDA label and compendia listing. Now, over the years, there have been a number of CMS recognized compendia. The reason that's important is because CMS coverage policy is actually dictated by law. Commercial payers technically are not bound by that same law. However, the majority of states have passed rules from the Insurance Commission, if you will, that that require the same sort of coverage policy for commercial payers. So the way it stands now is that commercial payers will pay for FDA labeled indications and they'll pay for compendia listing and, as it turns out, these days NCCN compendia is the one that is most commonly referred to, and it's been that way for years now. Yes, they clearly pay close attention to what it says. They pay close attention to what it says in the guideline. They pay close attention to what it says in the footnotes. They pay close attention to what it says in the text. And of course, they pay close attention to the compendia, which is a derivative of the guidelines. Now, we should be very clear that coverage is different than access. Let me explain what I mean by that. Coverage means the insurance company says, we cover it. But there's been a lot of discussion now about having preferred agents. Doesn't mean the non-preferred agent's not covered. It might be covered, but access is dictated by, let's say, formulary placement or placement on a pathway or something like that. We have not seen a ton of that yet, but as we'll discuss, in patients who are being treated with chronic lymphocytic leukemia, there's actually a lot of treatment choices now. And there are multiple drugs in the class. And that opens the opportunity for payers to consider access and specifically favoring one agent within the class over another if they're otherwise pretty much interchangeable. There were some interesting presentations at ASH regarding durability of response, regarding managing toxicity, regarding combinations that heretofore have not really been in the mainstream. Some of those presentations are very, very interesting. So, for example, we had a presentation on the durability of ibrutinib and mantle cell. It's pretty durable, which is good. I don't have a dog in this fight, so I look at this and I think, well, that's probably a class, right? So it's probably going to be true of acalabrutinib and zanubrutinib. Whether one is going to wind up being superior to another will remain to be seen. I think the other thing that's interesting about that class, for example, is whether or not there are going to be toxicity differences, because they really are different agents. And the toxicity profile may ultimately impact the drug of choice. And then, of course, we haven't even started talking about cost. These drugs are very, very expensive. And on the one hand, durable is good. On the other hand, durable means cumulative cost is high. We have this tension right now in hematological malignancies between a concept that we have fallen in love with the last few years, which is turning cancer into a chronic disease. And we've flipped that on its ear, and we're thinking about, can we actually cure some of these cancers? That's the CAR T thing, right? So we're going to continue to experience this this tension. It's so interesting to me because, as you may know, ICER looked at a cost-effectiveness profile for the CAR T therapies. And the way they looked at it was they looked at milestones and for projected durability and whether or not CAR T would be cost-effective at different time points. And there's clearly a point at which it becomes cost-effective if it's that durable. The problem is we don't know right now if it's that durable. It costs a lot of money up front. That's a whole different issue regarding healthcare financing. But if you can offer a therapy and cure the patient is that theoretically a better approach than taking a pill every day forever? And I think a lot of people would say yes, that's better. We'll see.